Thanks, Pat, for the introduction. So I know this is a passionate topic. You must have done needs assessment and wanted this topic, so I will tell you some things about MRSA that we deal with in the hospital setting, but also I will have portions towards the latter half of the talk that deal with school issues. So it's a little tough to get started with talk after nice lunch, but hopefully you will stay awake. So you guess that MRSA is a big deal, right? For infectious diseases, and you working in the school system obviously see this as a big problem. And we in the healthcare field here in the hospitals and clinics, it's even a bigger deal. And in fact, in infectious disease, my own subspecialty, it is in fact probably close to half of my consultations in the hospital setting have something to do with staph infection. As a matter of fact, yesterday I did a consult on a 15-month-old child who had necrotizing fasciitis, starting from the groin to the lower half, required fasciotomies on the abdomen, a couple of scars. And I thought it was going to be group A strep infection. And I went to the lab and they said, no, it's Staph aureus. Okay? So the way it presents has changed. It's much nastier. It's not just resistance. It actually is more aggressive bug as well. So a couple of years back in 2006, Infectious Disease Society of America actually declared this bug a superbug. Now you are familiar with seeing the type of skin infection kids come with in the school setting. And this is of course, a big bad boil. And this obviously has a deeper abscess formation. So it's like a carbuncle. And this type of infection really requires drainage. So I just want to show you among the types of lesions you will see in the school, this will be pretty nasty. I think most of the times you see simple impetigo. You see that too? All right. Okay, I didn't know that. Lord, so maybe you guys just handle them and they never make it to our clinics. All right, so we have three distinct phenomena actually that have been happening. First is the resistance issue, which is what methicillin-resistant staph implies. But we also have this new problem, that is that these kids are getting a lot of abscesses, right? Staph has been around for a long time, but we hadn't dealt with as many abscesses and as many recurrences. So the third one is relapses and recurrence is also a separate phenomenon from resistance, separate phenomenon from the abscess formation. It also causes recurrence. So we got a lot of things that kind of converged and causing this healthcare crisis right now. One of the things we have found through research is that this type of epidemic we are seeing is due to very few groups of bugs in the Staph aureus family. And they are USA 300 clone. So they are pretty much uniform in terms of where they came from and how they have spread. There is USA 100 clone also, which is the second commonest clone. So it's not like old staph just becoming nasty. This is staph that became nasty somewhere, and then it just spread. Now, we have been tracking this trend early on. So this whole epidemic we are watching today, it actually began in year 2000. And I had my residents look at this issue. This is adult setting. I have two slides. This is adults. And if you want to look at methicillin resistance, you have to look at oxacillin, which is this top line. And in the adult setting, staph infection was not common. So if you saw staph infection in the old days, it was usually hospital-acquired. And hospital-acquired staph was usually methicillin resistant. But it's a different bug than what we are seeing in the community. So that incidence was already 50% in year 2000. It went to maybe around 60% in a matter of 2 years. But if you look at the pediatric setting, very different. This is UTMB data. It was less than 5% in 2000, and in a matter of 2 years, okay, it went to almost 65%. So this was a dramatic increase, right? Now, the other thing we want to watch is that the clindamycin and Bactrim, which are our other options, they have remained pretty uniform. But if you look at the adult world, because this was hospital-acquired, by and large in those days, they also have high levels of clindamycin resistant. So they don't use clindamycin very much in the adult medicine. But if you look at pediatrics, our kids, that if you see some of your physicians prescribing antibiotics, it includes clindamycin liberally. But it's very uncommon in the adult setting. Okay, so staph can be nasty through a variety of mechanisms. It can produce a lot of enzymes and toxins, and different clones have different amount of this kind of toxins, so they produce different form of disease. One of the toxins actually produces toxic shock syndrome that some of you may be familiar with. And another thing that makes this bug unique, and this may be where the bugs is not the resistant issue, but where the bug becomes nasty in terms of forming abscesses and invasiveness, is that these bugs now, this community-acquired Staph aureus that is methicillin resistant, it has this property of producing Pantone Valentine leukocidine, and you don't have to pay too much attention. Just that this is probably one of the important enzymes that's thought to lead to these kind of necrotic large lesions. Okay, so let's separate out these two bugs in how they compare and contrast. Looking at staph coming from the healthcare facility compared to community setting. So the community setting staph, of course, is MRSA, so it's resistant to oxacillin. That's how you look at staph. When you call MRSA, you can look at, depending on the lab may say it's methicillin, or it may say it's oxacillin, or it may even say cloxacillin. All those are MRSA bugs. So but the community-acquired strains do not have the Bactrim and Clinda resistance as much as the hospital-acquired strains. They are usually PVL, the leukocidine that I was talking about, positive, and they cause a lot of these necrotizing lesions, whereas the hospital-acquired staph usually causes, infections at the nosocomial site, such as if you're on a ventilator, it may cause pneumonia, or if you have surgical wound, it may cause wound infection. So it's a little different than the way we see the staph that is MRSA in the community. So let's just focus on the outpatient setting. One of the other projects we did a long time back with the residents was to look at outcome of these boils and abscesses when kids are seen in the clinic or emergency room, and when we used right or wrong antibiotic. Because early in the epidemic, we didn't know for MRSA we couldn't use a drug called Keflex. You guys know Keflex, right? It's a cephalosporin. It's not good for MRSA, but that was the common antibiotic. So we know most of these kids coming to the clinic were going to get Keflex. But also some kids were getting drained with an incision. So if you look at when kids were given inappropriate antibiotic, this slide is only for inappropriate antibiotic, but if you drained it, you had 100% success, okay? If you did not drain it, you had only about 21% success. So we know from this staph that drainage is a big deal because of this PVL and the abscess formation capacity of this bug. If you drain it, even if you are not careful with the antibiotic, you could get success. Of course, if you use the right antibiotic and you drained or did not drain it, you still have better success. So getting right antibiotic and draining is critical. Okay, so let's look at different types of antibiotics that you can treat. So if you ask children coming to school, they may have different types of antibiotics. You want to see whether they would work or not. So amoxicillin, which is a common antibiotic we use for ear infection, is no good for any kind of staph, whether it's MRSA or what's called methicillin susceptible. It is usually worthless. Now, MRSA has become resistant in terms of resistance to penicillin antibiotic, not because of beta-lactamase production, which is how methicillin-sensitive bugs are resistant to staph through beta-lactamase production, but MRSA is resistant through penicillin-binding protein change. Okay, so there are two separate mechanisms. So MRSA has both. It has both beta-lactamase production, but also penicillin-binding proteins have changed. So penicillins would not work, and neither would cephalosporins for MRSA. So all cephalosporins and all penicillins are beta-lactam antibiotics. So once you have MRSA, then none of these cephalosporin and penicillins are effective. That's important to remember. Whereas if it is MSSA, you can use Keflex and Augmentin and dicloxacillin. Now let's come to erythromycin, and with erythromycin you can say azithromycin, clarithromycin. You've all heard of Z-Pak, right? Which is azithromycin, commonly used for a lot of infections. So staph, if you look at susceptibility for erythromycin or clarithromycin or azithromycin, only about 20% of the bugs are susceptible. And clindamycin, on the other hand, is about 90% susceptible. It is a separate mechanism of resistance, but it is better than using erythromycin. Now, if you look at other groups of antibiotics on this page, Bactrim, pretty good for both MRSA and MSSA, 95%. If you look at doxycycline, our good old antibiotic that wasn't used much for anything, it has made, there is a resurgence of its use based on its activity against MRSA, which is actually very good, but it's not for young children, right? So under age 8, we don't use it. But if you have a teenage child in the clinic, the physician or one of the nurse practitioners can easily prescribe doxycycline. It's cheap. It does have photosensitivity, so you have to remember that. And we still have limited data in large-scale use in the current epidemic. So we still have little caution about its use. Linezolid, Zyvox, you heard of that? What do you think about that drug? It's pretty good for both. You know how expensive it is? Very expensive. Each pill, 1 day, is $125. So 10-day course is $1,500, easy. $1,200 is the minimum price you will pay. So you just don't want to use Zyvox unless you pay $50 for infectious disease consult, which would be cheaper than Zyvox, and maybe we'll use doxycycline, which is $10. So linezolid is to be used with a lot of caution. There has to be a real good reason why a physician has to use that. You could use it for clindamycin and Bactrim-resistant staph, which is less than 2%, okay? But it has to have a real use for it. So you have to be probably just not using it. Now, rifampin, which is an add-on antibiotic, is for synergism. We shouldn't be using rifampin alone, okay? But we do use it for complex skin infections. So if you have kids coming to school, they have been in the hospital, don't be surprised if they have gone home on 2 antibiotics, clindamycin and rifampin, common, Bactrim and rifampin. Levofloxacin or Levoquin, which is very broadly used in adults, will be uncommon for you to see in kids. But again, teenagers do have adult type of medicines prescribed to them. I would not recommend it for staph in general. You have rapid emergence of resistance. In fact, emergence of resistance can occur in the same person where you are treating it. Usually resistance takes time and is a population-wide phenomenon over many years. In this case, you can have de novo resistance in an individual patient. So we are very afraid of quinolones in staph infection unless you have some specific reason. So management in general includes drainage, culture. I, as an infectious disease doc, no matter what infection I'm treating or what I recommend for you to treat, whether it's bladder infection or staph infection, wherever, get a culture. You will have so much reassurance downstream. When patient doesn't get better, when he's resistant, you have a lot of information ahead of you. So always get a culture, because we have complex resistance pattern with staph. Sometimes it's Clinda resistant, sometimes it is Bactrim resistant. You really want to know something. So drain it. The top 2 antibiotics still are Bactrim and Clinda. Some physicians prefer Bactrim as initial choice. I have no problem with that. But Bactrim is relatively high dose. So if you're an adult, I'd rather use 2 double-strength tablets twice a day instead of 1 double-strength tablet twice a day, which is for UTI, okay? So the amount of antibiotic required to kill staph is much higher than E. coli in the urine, okay? So you have to remember that. These are slightly different dosages. And if you have this group A strep infection, because about 10% of impetigo can be co-infected, or it could be strep and not staph, okay? Bactrim will not work for group A strep impetigo. Now, fortunately, I would say, and maybe unfortunately, staph now is so much more predominant that strep has kind of fallen off the radar screen, and we do see staph much more than in the past. But if you, like this child I was talking to about this morning when I swore that this necrotizing fasciitis was going to be from group A strep, this child was already in Bactrim for 2 days before this whole thing got spread, okay? So this was a spreading infection for staph that was Bactrim therapy ongoing. So Bactrim is okay for simple infections, but I don't have faith in Bactrim for severe infections. And definitely not for group A strep. So again, culture would have guided you. If you do a culture, you started on Bactrim first. When the culture comes back group A strep, you just change it to penicillin. Bactrim will not work. All right, for inpatients, the FDA has only few drugs approved for. We use a lot of drugs without FDA approval because some of the usages are new. Drug companies are no longer going to do new trials. Some of these are generic drugs, so nobody's going to do trials. So we don't have, for example, Bactrim. There is no randomized study of Bactrim for staph infection. Never has been. Okay. Okay. So if you look at approved drugs, on this side is community-acquired skin and soft tissue staph infection. Linezolid, which is available both at IV and PO, vancomycin, daptomycin, tigecycline, ceftaroline. You can see all these are IV except linezolid, right? For nosocomial pneumonia, the FDA indications are linezolid and vancomycin. Daptomycin cannot be used, but that's not part of your important talk. What I'm saying is many of these staph infections, antibiotics approved, are just IV, and they're only for hospital setting. Let's then switch gear towards recurrences, which is one of the things you deal with very often in school setting. So why do these recurrences occur? Obviously, the bug has changed, and I dealt with that earlier on. So there's something unusual about this bug. They just tends to hang around for a long time. And when people have recurrences and you do molecular studies, you find it's the same bug that you had it last time. It's not something new you acquired from another person now, although that can happen, but usually it's your own bug coming back. So there have been some studies looking at where is this bug hiding. So we have also done project here, and what we find is that, especially in young children, it is a skin that is heavily colonized. When MRSA epidemic first started, as we noticed in around year 2000, the older guideline for MRSA, which used to be hospital acquired, you use what? Mupirocin or Bactroban in the nose as part of prevention of infection. When we are doing these consults in pediatrics early on, we found a lot of kids were already coming with mupirocin treatment and they were still having recurrences. So since then we know skin colonization is probably even more important when you have recurrences. Okay, so that's just important part because when you do prevention of recurrences, mupirocin will play a relatively small role. Okay? Now, the other phenomenon we will see in high school settings is this ping pong phenomenon, right? So you may have recurrence, you may have a less than occurrence today, you resolved it, another person is colonized, and he gives it back to you. Okay? Or he gives it to another person. So we have this phenomenon. So when you want to stop recurrences, you have to look at it as a group intervention. Sometimes it's a family intervention. Sometimes it's a school intervention. So you have to decide where the problem lies. So for recurrent or serious infection, our goal is to eliminate colonization, which can include combination of things. We don't do everything in every person, but we look at it as an individual kind of decision. So it's not unusual to say, okay, for recurrence, let's do mupirocin first. That's fine. But I would almost always do skin decontamination. So skin decontamination, I'll have a next slide on that. How do you do that? The other thing is paying attention to hand washing, right? And bathing with disinfectants, as I said, that will be in the next slide. In some patients, when I have done decolonization, I have done nasal decolonization, skin and nasal decolonization, are still having recurrences, they go on long-term Bactrim suppressive prophylaxis. That usually works. But again, it's not going to be your initial approach for a child. You would have gone through other approaches. Again, that's when you need infectious disease consultation. So the decontamination protocols, there is nothing that is standardized. I have my own favorite recipe, and doctors often ask me, what do you do? And when I'm not on service and my other colleague is on service, they'll tell you something else, okay? And I cannot say they are wrong. So because we have nothing standardized. How many of you, let me ask this in the school, school setting. How many of you have had kids where they said, the doctor said, you're going to use bleach for decontamination? I see a lot of hands going up. How many of you have had child, they said, okay, the decontamination is with HibiClen? Yep. How about Betadine? Very few, maybe one or two. I've used Betadine, by the way. So we have no standardized approach. Now, how do these things work? So if you're going to use Phisohex or HibiClen, which is Chlorhexidine or hexachlorophene, these are surgical scrubs, right? We use them in the hospital setting, and actually they will use them in the OR. But how does a surgeon use it? They scrub and scrub and scrub. Okay? This has to be used both as a soap, but it has to be with scrubbing effect for a long time. So it's not like you tell them, take this HibiClen, and they just put some in the palms and they go like this and take a shower. It's not going to work that way. They have to use a washcloth. Okay? They'll put a lot of these HibiClen, and I tell them to scrub their cracks and everything, and the armpits. Just, you got to get to all your hidden spots. Okay. Betadine, again, total body application. You can dilute it. HibiClen is not to be diluted. All right? Betadine, you can dilute it like 1:2, 1:3 with water. Use a washcloth. Apply it all over the body, but you have to let it dry. Okay? You have to let it dry for about 3 to 5 minutes. Now, that's a little bit of a trick, isn't it? You're doing it in the shower, you're drying it, and you're applying, then you just hang out there for 3 minutes. All right? So that's hard, but I've done it. Now, the other one is bleach, and this is the tricky one. It might be the cheapest one, but it's the trickiest one. How do you use bleach? Bleach action requires soaking. So don't forget, HibiClen scrubbing, Betadine drying, bleach soaking. And how do you soak body? Who takes when was the last time you took a bath in a bathtub? Ooh, nurses are very clean. Quite a few. Many of patients I see haven't sat in a bathtub for a long time. In fact, there are many new homes you buy, they just have a shower in them. They don't have a bathtub anymore. So you have to sit in a bathtub. Then the next question is, how much do you put the water? Because the colonization can be in the armpits, it can be in the neck fold. Okay? So do you go up to here and you sit there? And this could be a 3-year-old child. So it's easier said than done. In fact, I can tell you almost every child I've seen bleach instruction given and come to my clinic, they have never been told how to use it. Okay? So I actually, while I accept that people can prescribe it, there is no published protocol on how to do it or how often. My favorite is HibiClen followed by Betadine. I did a project on Betadine where we showed that it actually worked. Okay? HibiClen works because there are studies in adults, especially in prison setting, where there are a lot of epidemics, and it seems to work. So those two have proven things. Bleach may work, but we really don't know how to use it. Okay, so the duration is not very clear also. I generally say, depending on, I've had patients who've had recurrences for 1 year, 2 years, okay, and they get it every month. Then I do more prolonged decolonization in those people. So, usually initially it's daily for a couple of days, followed by 2 to 3 times a week for a month. So usually of recurrences, I go through a decontamination protocol for a month. And often I look at the family and I say, everybody in the family will do that, at least in the first week, even if the family members have no recurrences, because they could be the colonizers giving it to the kid. Prevention of MRSA in athletic setting, you have to have a plan. Don't deal with it as just one patient coming to you. You must have a policy. You must have a meeting. You must have a policy which says every athlete is going to have a handout. Every athlete or every team is going to have a lecture on a routine basis. How many of the schools do that? Ooh, no hand went up this time. So that's your homework. Today you want to get assignments, right? You want to identify what you can do next, right? That's going to be on your list of things to do. Develop a policy. And make sure you have supplies available, because you can have a policy, every athlete should go and wash hands with HibiClen, and then there is no HibiClen in the bathroom. Or you might say use alcohol gel, and you may not have alcohol gel. or some schools have a problem with it because of codes, right? Is a fire hazard, and I've seen some schools don't have it. Okay, the other thing is about having supplies for athletes when they have cuts and bruises and wounds. And so this is how you look at child or a school kid who is an athlete. If they have a wound, the wound must be covered and contained. You must shower immediately after participation. Again, this is without having any infection. This is just general policy. Shower before using whirlpools. Wash and dry uniform after each use, which I don't know. All right. Report possible infection to the coach and athlete. So you must tell the athletes, because a lot of athletes have a boil. They never tell anybody. Okay? You have a policy. Well, the kids have to be told. You have to do that. Okay, next is that if you have a wound, the athletes can be excluded if the wound cannot be covered properly. Okay? But if it is properly covered, that means that the wound is securely attached with a bandage or covered by a securely attached bandage and dressing that will contain all the drainage. Okay? And the other one is that it has to, if the wound can be properly covered, you must have good hygiene measures, such as washing hands, right, before and after changing bandages, and throwing away used bandages in the trash. Next is that the healthcare provider may exclude an athlete if the activity that they're participating is a risk to the patient. If you have a wound and you want to play football, that could be a problem because you can get hurt. Next is that if you have an open wound, these athletes should not be using whirlpools. And if they're using equipment which could be exposed to the contaminated wounds, you must clean it properly, and you must use proper disinfectants. Okay? Now, I'll tell you where to get that information. Athletics facilities such as locker rooms should always be kept clean, whether or not MRSA infection occurred. That's a challenge. So the part of that requires you to have, also conversation with your janitorial staff. They should be in your policy. When you develop a policy, it should include them. So you have to review the cleaning procedures. You want to make sure they're using proper decontaminants that are active against MRSA. You can get a lot more information on MRSA at this CDC website. And actually, many of the things I said about the athletes and the school, they have a separate document on that. So, again, we reviewed quickly the nasty features of this bug and how tricky it has become in terms of managing it and preventing it. And so in summary, school nurses are, I think, an important part of the containment of MRSA epidemic. One last slide, just as a plug for our next conference coming up. We do host from the Department of Pediatrics here at UTMB an annual CME conference. This year it will be the Moody Gardens Hotel. It's a 2-day conference. It's targeted for both nurses and physicians, and physician assistants. So you are all welcome to register. There is that website. It's not open for registration, but I do invite you back to Galveston. Thank you.